Hello everyone. Today we are going to discuss very important topic which is guideline for the evaluation and diagnosis of chest pain. These are based on 2021 AHA and ACC guidelines and they are available online on ACC website. Now before going into the exact guidelines, it's important to understand two different things. That's class of recommendation, what they called as COR, and the level of evidence, that's LOE. So class of recommendation is based on benefits and risks. So like for example, class 1 recommendation, that's a strong recommendation where they would write words like that this treatment is recommended or is indicated or this procedure should be performed. And class 2A recommendation is moderate benefit over risk. So benefit is still outweighing the risk, so they would write statements like it is reasonable, this can be useful, or this can be still effective. Class 2B is a weak recommendation where benefit is more than or equal to risk, and class 3 recommendation are you have no benefit, so benefit and risk are equal. And class 3 recommendation harm is that the risks are more than the benefit. So we want to focus on more class 1 recommendation and class 2A recommendation where they have strong or moderate recommendation. And if we talk about the level of evidence, so level of evidence would be level A, which is high quality from more than one randomized controlled trial. Level of evidence BR is level of evidence B, that's mainly coming from randomized trial. Level of evidence BNR is mainly coming from non-randomized trial. Level of evidence C LD is that it's coming from limited data, and level of evidence CEO is that it's coming based on expert opinion, based on the clinical experience. So it's important to keep in mind various class of recommendation and level of evidence, which ultimately is responsible to weigh clinical strategies, interventions, treatments, diagnostic testing in patient care while we are talking about guidelines for chest pain. Now it is very simple to understand that why we should know about chest pain, right? Chest pain after injuries is the most common reason for adults to present to the emergency department, and it accounts for more than 6.5 million visits a year, and that's basically 4.7% of all ED visits, and it also accounts for 4 million outpatient visits annually. And we all know that coronary artery disease remains the leading cause of death in men and women. So it's important to understand chest pain. So we want to know whether this is a serious cause of chest pain or benign cause of chest pain. Since 20 to 40% of all the population of United States would experience chest pain at some point in their life. Now, it's also interesting to note that if a patient is coming with chest pain, of all the ED visits of chest pain, so we talked about more than 6.5 million ED visits, only 5.1% will have acute coronary syndrome, and more than half will ultimately be found to have non-cardiac cause of chest pain. Nevertheless, chest pain is the most common symptom of coronary artery disease in both men and women, so it's still important to know exact evaluation and cause of chest pain. Now first let's talk about defining chest pain. Now historically we all have been using three kind of chest pain, especially when we are talking about cardiac chest pain. So first one is the typical chest pain, the second one historically we have been telling atypical chest pain, and the third one is non-cardiac chest pain. So there are three important criteria. So if the location is typical, like substernal chest discomfort or chest pain, which is provoked with exertional, and then the third one is relieved with rest or nitroglycerin. So if we have all three, then we call a classic chest pain or cardiac chest pain. If we have two of these three symptoms, then earlier they used to call atypical chest pain, but atypical kind of confuses that it could be non-cardiac chest pain as well. So a better term is to use possibly cardiac. And third is if you have 0 or 1 of about these 3 symptoms which I mentioned, that's the typical location, provoked with exercise and relieved with rest and nitroglycerin. If you have 0 or 1 of about 3, then we call it as a non-cardiac chest pain. So right now the recommendations are that you should not describe chest pain as atypical. So now the new 3 categories which we just talked about are cardiac, possibly cardiac, and non-cardiac. The other important thing is to attribute and determine the type of chest pain. Now, most of the times the patient would mention that it's more of a pressure or tightness or squeezing sensation or heaviness or burning sensation. Most of the times it is more of a chest discomfort than actual chest pain. So it is still okay to mention that this is a chest discomfort. Chest pain mostly is of origin, let's say if the patient is having sharp chest pain or fleeting, or chest pain which is worse with inspiration or position. These kind of chest pain usually have lower likelihood of ischemia. So broadly, you can also divide chest pain into acute or stable causes. Acute is when the patient is having new onset chest pain, or chest pain which is entirely different from the chest pain the patient has experienced. The stable chest pain is the patient can predict that kind of chest pain. Like for example, every time the patient walks, the patient ends up getting chest pain or chest discomfort. That's a stable chest discomfort or chest pain. So most important thing, our entire goal in why we are talking about this chest discomfort or chest pain is to find out the probability whether or find out the suspicion that this kind of chest pain or chest discomfort, is it ischemic in origin or is it non-ischemic in origin. So ultimately we are aiming to find the probability of ischemia. So if the patient complains of chest discomfort or chest pain which is central, patient is not able to point out to a specific region in the chest because heart is a visceral organ, right? So patient won't be able to point out to a specific region. So patient will point out to a broad region. So central pressure like squeezing like or gripping or heaviness or tightness or chest pain or discomfort which is exertional or retrosternal, these are more alarming. These are symptoms which increases the probability of ischemia, and especially if it's left-sided dull aching. Whereas if the patient complains of sharp right-sided tearing, burning, fleeting, shifting pleuritic or positional chest pain, these usually have low probability of ischemia. So our first thing which we talked about right now is how to define chest pain, and we learned that we define as cardiac, possibly cardiac, and non-cardiac chest pain. And the most important thing here is history. You want to find out what's the probability of ischemia. If the patient has all the symptoms like pressure, squeezing, then they have higher probability of ischemia. And if the patient has symptoms which is like sharp, fleeting, pleuritic, positional, they have low probability of ischemia. So classic kind of chest pain is someone who is having central retrosternal dull chest pain. Patient is not able to point out to a specific region in the chest, which is worse with exertion. That is let's say 7 out of 10 in intensity, squeezing, or like sensation that an elephant has put on the foot on the chest. So squeezing or gripping or heaviness sensation which can be worse with exertional, relieved with rest or nitroglycerin. This is more suspicious of ischemia. So next important thing is history. So a focused history. So you should ask the patient nature of the chest pain, onset and duration of chest pain, location, the area of radiation, precipitating factors, relieving factors, associated symptoms to identify the potential cardiac cause of chest pain. The reason why associated symptoms are very important is because women's and especially elderly women may have just non-specific associated symptoms. Like for example, they may have nausea, vomiting, shortness of breath, lightheadedness, pre-syncope, syncope, or vague abdominal symptoms. They are more frequent amongst diabetes or women and elderly patients. So that's why associated symptoms are very, very important. Now let's move on to physical examination. Now physical examination, it's important. Like for example, STEMI can be easily be recognized in EKG. The problem is, how would you recognize NSTEMI and other non-cardiac cause of chest pain? So you have to look out for important clues for other diagnoses. Like for example, if it's really acute coronary syndrome, the patient would be diaphoretic, tachypneic, tachycardic. You may find S3 or auscultation or mitral regurgitation murmur. And it's also important to keep in mind that the examination can be normal as well if the patient has acute coronary syndrome. Or let's say you find the patient is having pain with inspiration, that's the pleuritic chest pain associated with, let's say, tachycardia, shortness of breath. This could be pulmonary embolism. Or let's say if the patient has sudden onset sharp tearing chest pain, where you find blood pressure discrepancy in both the arms, and if you also see widened mediastinum in the chest x-ray, that means this is more suggestive of aortic dissection, especially in populations who have connective tissue disorders. Let's say if the patient is having chest pain, tympanic abdomen, you find subcutaneous emphysema, this could be more of esophageal rupture, right? And you may find other important clues in physical examination, like for example, if you see crescendo decrescendo murmur in the aortic area with pulsus parvus et tardus, this could be aortic stenosis, which can also come as which can also present as chest pain. Or early diastolic murmur, which signifies aortic regurgitation, which can also present as chest pain. Or hypertrophic cardiomyopathy, where you also have systolic murmur, which is not radiating to the carotid area. And you may find prominent A wave in the JVP, so that's hypertrophic cardiomyopathy. Or let's say if the patient is having positional chest pain, where the chest pain is increased in the supine position, relieved when bending forward. You also hear pericardial friction rub, so this is more of pericarditis. And let's say if someone is having localized chest pain, which is tender in the costochondral junction, this is more of costochondritis. Or if you see pain in around the skin and a dermatomal distribution, which is triggered by touch, and the patient has characteristic rash, that's more of herpes zoster. And then let's say if the patient is febrile, you have pleuritic chest pain or localized chest pain, you may hear pleural friction rub. How do you differentiate between pleural and pericardial friction rub? So if you ask the patient to hold their breath, the pleural friction rub would disappear, but pericardial friction rub would still stay. So if the patient is having fever, localized chest pain, pleuritic with pleural friction rub, that's more suggestive of pneumonia. One important thing to educate patients and all the population is, if you have chest pain or if your patient has chest pain, it's important to go to the emergency department via ambulance or via EMS and not by personal car. 1 out of every 300 patient who is transported by a private vehicle suffers cardiac arrest en route where you have no medical help. So the best and the ideal way of transportation to ER is via EMS. And there are many advantages of transfer by EMS, right? So number one is you can get a pre-hospital EKG and you can identify whether the patient has STEMI or not. The second one is the EMS personnel are trained in chest pain. They can load you with aspirin, treat relevant arrhythmias, implement defibrillation if needed. And the third important thing is the shorter time to travel to the emergency department. So now let's talk about diagnostic testing. So the most important thing is EKG. So if anyone is coming with chest pain, unless have a suspicion of non-cardiac cause of chest pain, and that's evident. But for all the patients, EKG should be obtained within 10 minutes of medical facility contact. So first important thing is EKG, regardless the cause of chest pain and regardless of the setting. So the most important thing is EKG within 10 minutes of arrival to the medical facility. And the second important thing is to obtain cardiac troponin. So that's high sensitive cardiac troponin should be measured as soon as possible after the presentation. Now, let's say if someone is coming with chest pain, you get history and do your physical exam, and the first thing you want to do within 10 minutes is get an EKG. Now, if EKG shows ST elevations, then you follow STEMI guidelines. If the EKG shows ST depressions, then you follow non-STEMI guidelines. If the EKG shows, let's say, diffuse ST elevation with PR segment depression, then it's a pericarditis. And if EKG is showing let's say new arrhythmias, then you follow the arrhythmia specific guidelines. But here the important thing which I want to say is, let's say if someone is coming with chest pain and the first EKG you obtain is normal, here the important thing is, if the symptoms are still persistent, you obtain a serial EKG. So a first normal EKG does not rule out ACS. So your decision making should not be solely based on a single normal or non-diagnostic EKG, since about 6% of the patients with evolving ACS are actually discharged from the ED with normal EKG. So important thing here is to get a serial EKG. So if the patient has persistent chest pain or change in the clinical symptoms, repeat the EKG and then manage accordingly. The other important thing to keep in mind is you also should keep in mind about supplemental electrocardiographic leads like V7 to V9 to rule out posterior MI. And also that if the patient has left circumflex or right coronary artery occlusions or posterior wall ischemia, these are often electrically silent. So for these patients, a right-sided EKG should also be considered, at least when it is suspected. Next important thing to obtain is chest X-ray. It's class 1 recommendation, and it's basically expert opinion, but it's kind of intuitive. If you get a chest X-ray, you can look for other potential cardiac, pulmonary or thoracic etiologies. What if the patient has rib fracture, or what if the patient has pneumonia? You can see signs of pulmonary congestion. You can look at the widened mediastinum, which can be suggestive of aortic dissection. You can also look at the size of the heart, which may suggest heart failure, though it's non-specific. So obtaining chest X-ray, which is kind of rapid, that's non-invasive, you can use to screen for several disorder if the patient is coming with chest pain. Now let's talk about some of the cardiac testing general consideration. The whole idea is we want to make sure that if the patient is intermediate or high risk, we choose the correct diagnostic modalities. Like for example, if the patient has acute coronary syndrome, or if the patient has high pre-test probability of coronary artery disease, then you want to use invasive coronary angiography. Or let's say, for example, if the patient has intermediate risk of coronary artery disease, the pre-test probability, and the patient is coming with acute chest pain, then you want to make sure that you order anatomic or functional testing. Or if the patient is low risk, then maybe no testing might be necessary. So the idea here is to be cost efficient and also try that we avoid layered testing, or like for example, if you order a stress test first, then you anyway have to order angiogram, then you would rather go towards angiogram directly. So that's the whole idea. And if we talk about the cost, the exercise EKG is the lowest cost as compared to the other procedures, with the exception of coronary artery calcium scoring. The other two definitions to keep in mind is obstructive coronary artery disease. So with convention, if you have coronary artery disease with more than 50% of stenosis, that's called as obstructive coronary artery disease. And if the coronary artery disease stenosis is less than 50%, then we call it as non-obstructive coronary artery disease. And then what is high risk coronary artery disease? That's when someone has obstructive stenosis of the left main, which is more than or equal to 50%, or if the patient has anatomically significant triple vessel disease, which has more than or equal to 70% stenosis. So these are the three conventional definition: non-obstructive coronary artery disease, obstructive coronary artery disease, and high-risk coronary artery disease. The other important definition in the guideline is known coronary artery disease. So what is known coronary artery disease? So this includes patients who had prior anatomic testing like invasive angiography or CCTA, which is coronary computed tomographic angiography. So CCTA. So known coronary artery disease includes patients who had both non-obstructive atherosclerotic plaque and obstructive CAD. So now you know three definitions: known CAD, non-obstructive CAD, obstructive CAD, and the fourth one is high risk CAD. And the high risk CAD is again who has obstructive left main stenosis more than or equal to 50%, or triple vessel disease more than or equal to 70%. Now let's talk a little bit about anatomic testing, and the first one we'll talk about will be CCTA, which is coronary computed tomography angiography. That's CCTA. Now this will help in diagnosing the extent and the severity of non-obstructive as well as obstructive CAD. It can also help us to know the high-risk features, whether we have positive remodeling, meaning the plaque, instead of going in the vessel, it has outward vessel expansion, so it actually hides the plaque burden. The plaque is growing laterally rather than the inward growth. So you will say that, the stenosis may be, let's say, less than 50%, but the plaque is growing laterally. So that's called as positive remodeling. So that's a high risk feature. So you can know that in CCTA. The other one is low attenuation plaque, like for example less than 30 Hounsfield unit. So low attenuation plaques are usually lipid rich and they are prone to rupture. And different spotty calcifications like small punctate calcium deposits, which can be associated with plaque instability. So you can know high risk features in CCTA. And these days, CCTAs would also help us calculate fractional flow reserve with CT, that's FFR-CT, to provide an estimate of lesion-specific ischemia. So what is FFR, or fractional flow reserve? So it can calculate the pressure after the blockade and pressure before the blockade. Traditionally, you have to insert a wire into the coronary artery in the cath lab to estimate the pressure, but you can also do it with the FFR-CT and with the CCTA. So what is FFR? That's the pressure after the blockade of the lesion divided by pressure before the blockade. Like for example, let's say the aortic pressure is 100 and the distal coronary pressure is 75. So your FFR-CT would be 75 divided by 100, that's 0.75. So any FFR of less than or equal to 0.8 is a flow limiting lesion, so ischemia is present, so that would likely need stent or intervention. If the FFR is more than 0.8, that is likely safe to manage with medication. So the question now is when to order CCTA. So if the pretest probability is very low or low, then no testing is necessary. You can give the patient option of coronary artery calcium scoring for ASCVD risk stratification. What if the pretest probability is intermediate? Now for intermediate pretest probability, if the patient is young, then less than 65, or a less obstructive CAD is suspected, here you would choose CCTA, or CCTA is favored. If the patient has intermediate pretest probability and the patient is old, more than 65, or you suspect more obstructive CAD, then a stress testing is favored. So our goal basically when you order CCTA we are ordering in younger patient or when we are suspecting less obstructive CAD. Our goal is to rule out obstructive coronary artery disease and basically detect non-obstructive coronary artery disease. And it of course depends on availability and expertise. And you also have to keep in mind about contraindications of CCTA, like if the patient has allergy to iodinated contrast, or if you suspect pregnancy, or if the pregnancy test is positive, because CCTA would involve exposure to radiation. And if the patient is of course clinically unstable, or patient has renal impairment as defined by local protocols, like certain institutions would avoid CCTA if the eGFR is less than certain amount, or if the patient has contraindications to beta blockers or nitroglycerins if needed, or if there are presence of arrhythmias. So these are probably the contraindications of CCTA. Now, let's say if the patient has intermediate pretest probability and the patient is old, more than 65, or when you suspect more obstructive CAD, or if the prior CCTA is inconclusive, these all scenarios favors use of stress imaging. So our goal is ischemia guided management. And the stress imaging here, when we are talking about, is when we are thinking about exercise ECG. That's the first one. The second one is echocardiography or stress echocardiography. Then we have stress nuclear testing like PET or SPECT. So PET is going to be positron emission tomography, or SPECT, which is single photon emission computed tomography. So it could be stress nuclear like PET or SPECT MPI, which is myocardial perfusion imaging. Then we also have different other options like magnetic resonance imaging, like CMR, cardiovascular magnetic resonance. So now when we talk about exercise EKG, who are the candidates for exercise EKG? So those would be without disabling comorbidities like frailty, marked obesities, peripheral arterial disease, COPD, some orthopedic limitations, or these candidates should be able to achieve more than or equal to 5 METs, metabolic equivalents of exercise. And the second important thing would be the resting EKG should not have ST and T abnormalities. Like, for example, it shouldn't have ST depressions or left ventricular hypertrophy or paced rhythm or left bundle branch or WPW pattern or digitalis use, which would have baseline EKG changes. So these are the ideal candidates for exercise EKG, and these exercise EKG would have contraindications as well. Like, so if someone has baseline STT changes, you don't want to do exercise EKG, or if someone is not able to achieve more than or equal to 5 METs, or exercise is unsafe for them. And of course, if someone is having active acute coronary syndrome or uncontrolled heart failure or significant cardiac arrhythmias like VTAC or AV block, or high risk of arrhythmias because of QT prolongation, severe symptomatic aortic stenosis, and if the patient has severe systemic arterial hypertension, like with blood pressure of more than 200/100, you want to avoid exercise EKG. And of course, if the patient is acutely ill, like if the patient has acute PE or myocarditis, pericarditis, or acute dissection, you want to avoid. So that's a contraindication of exercise EKG. When we are talking about stress nuclear tests like PET or SPECT, we use radioactive isotopes, and the radiation exposure is about 3 millisieverts in rest and stress PET test. So the radioactive isotope used in PET scan is RB82, that's rubidium 82, and the radiation exposure in SPECT scan is about 10 millisieverts, and the radioactive isotope here is technetium 99M, that's TC99M, and RB82 is for PET scan. In the PET scan, you can calculate something called as MBFR, that's myocardial blood flow reserve. That is the myocardial blood flow during the stress test divided by myocardial blood flow at the rest. So if the MBFR value is less, that means the myocardial blood flow at the rest was high, and during stress test it was low. So any number more than or equal to 2 is normal, and if the number is less than 1.5, so it often indicates some micro or macrovascular disease. So if the number is low, it means that there's a limited ability to increase the blood flow. This may indicate blockage or some microvascular disease or some atherosclerosis. Now, the contraindications for stress nuclear imaging would be pot obvious, like if the patient is unstable or has acute coronary syndrome, if there is any contraindication to vasodilator administration, if the patient has significant arrhythmias or AV blocks, significant hypotension or severe hypertensions like blood pressures more than 200 over 110, if the patient has hypersensitivity to adenosine or regadenoson, or if the patient has recently used dipyridamole or dipyridamole containing medications. These are some of the contraindications for stress nuclear imaging. And for stress echocardiography, if you are ordering, some of the contraindications are if the patient has uncontrolled AFib or critical aortic stenosis or LVOT obstruction, or if the patient has contraindications to atropine like glaucoma, myasthenia gravis, obstructive uropathy, if the patient has severe hypertension, and other would be if the patient has limited acoustic window, like for example in COPD patients, or inability to reach target heart rate, uncontrolled heart failure, acute coronary syndrome. These are some of the contraindications of stress echocardiography. And then the last one is cardiovascular magnetic resonance imaging, or stress CMR. It can help to determine myocardial viability, and it can also differentiate acute versus chronic MI and other causes of acute chest pain like myocarditis. And the contraindications include reduced GFR and the same contraindications to vasodilator administration, or if the patient has some implanted devices which are not safe for CMR or which can produce artifact, or if the patient is significant claustrophobic, or the patient has used caffeine in last 12 hours. Now, once you determine that the chest pain is likely from, let's say, suspected ACS, we have different pathways. So, let's say, for example, first we talked about, let's say, someone is coming with chest pain, and if you have to further delineate whether this is acute chest pain or chronic chest pain. If it's an acute chest pain, focus on history and physical exam, get an EKG. If you find a potential cardiac cause, the first thing you want to rule out is STEMI. If you have STEMI, then we follow the STEMI guidelines. If not STEMI, then we have to evaluate based on the suspected etiology, based on the patient-centric algorithm. If you are thinking about ACS, which is not STEMI, then you use that pathway. If you are thinking about acute aortic syndrome, then you use that pathway: pulmonary embolism, acute myopericarditis, or valvular heart disease. So in this podcast, we are going to specifically focus on acute coronary syndrome, not including STEMI. Now, once we are committed to the pathway, let's say someone is having acute chest pain and acute suspected acute coronary syndrome, which is not involving STEMI, then our next step is to determine and categorize the risk strata into low, intermediate, and high risk, which can facilitate disposition and subsequent diagnostic testing. And the appropriate time interval, especially if we are using high sensitivity troponin, is to test it in 1 to 3 hours. So you first test it in time 0, and then you repeat the measurements in 1 to 3 hours for the high sensitivity troponin, and then 3 to 6 hours for the conventional troponin assay. But we are gonna stick to the high sensitivity troponin, which is now widely used. Now, to have these risk stratas of low risk, intermediate risk, and high risk, we have different CDPs, or also called as clinical decision pathways, to define risk. Like for example, we have heart pathway, EDAX or EDA, CS pathway or ADAPT pathway, NOTR pathway, 2020 high sensitivity troponin or cardiac troponin pathway, and then 2016 ESC or GRACE pathway. So if we talk about, let's say, heart pathway, it has variables including history. So what's your history, the EKG finding, age, risk factors, and then troponin. And then you can divide into low risk, intermediate risk, and high risk. So low risk would be heart score of less than 3, intermediate risk would be heart score of 4 to 6, high risk would be heart score of 7 to 10. So this will give you the risk stratification for someone coming with acute chest pain, and this is excluding STEMI. And then your target population is suspected acute coronary syndrome, and then it gives you the pre-test probability of low risk, intermediate risk, and high risk. Similarly, you can have EDAX pathway, that's EDACS pathway. Then you can have ADAPT pathway, where you can actually calculate TIMI score. So TIMI score of 0 would be low risk, TIMI score of 2 to 4 would be intermediate risk, and TIMI score of 5 to 6 would be high risk. And then you'll have different other pathways as well, like GRACE score to stratify into low risk and intermediate risk and high risk. The good thing about these all pathways, regardless of what you use, their sensitivity is close to 100%, except for about the GRACE pathway or the 2016 ESC pathway, which has sensitivity of about 96.7%. It's also important to keep in mind the warranty period for prior cardiac testing. Like, for example, if the patient underwent anatomic testing, like with a coronary angiogram or with CCTA, which did not reveal any stenosis or plaque, the warranty period is about 2 years. And let's say if the patient underwent stress test and the stress test was normal, given adequate stress response, the warranty period is about 1 year. The warranty period for normal stress and rest SPECT is highly variable because it's primarily determined by the type of stress, the patient's clinical characteristics, and the left ventricular ejection fraction. So now, what are the recommendations for low risk patients, like for the patients whose heart pathway score is less than or equal to 3? So for these low risk patients are those, so they have probability of major adverse cardiovascular events within 30 days is less than or equal to 1%. So these patients can be sent home and can be discharged, and usually no workup is necessary, but sometimes outpatient coronary artery calcium scoring or coronary artery calcium scanning can provide some additional information and risk stratification. Now let's move on to the intermediate risk patients who are coming with acute chest pain. So first thing you want to do for intermediate risk patients is to get a transthoracic echocardiogram, a quick bedside test which can help in establishing the baseline ventricular function, valvular function, evaluate for wall motion abnormalities, and to assess for pericardial effusion. And for intermediate risk patients who are coming with acute chest pain, management in observation unit is reasonable to shorten the length of stay and lower the cost relative to inpatient admission. Now let's say if someone is coming with acute chest pain and your pretest probability is intermediate risk and the patient has no known coronary artery disease. So the next thing you want to look at is the prior testing. So if the patient underwent prior testing and the recent test was negative, meaning if CCTA was negative in 2 years, or a recent stress test was negative in 1 year, or coronary angiography was negative in the last 2 years, then you can discharge the patient. And then let's say if the patient underwent testing but the previous testing was inconclusive or mildly abnormal, then you can consider CCTA. And If CCTA is inconclusive, then the next thing you can do is FFR CT to look at the flow limiting ischemia. If the FFR CT is less than or equal to 0.8, then this patient needs invasive coronary angiography. And then let's say if the patient had prior moderate to severely abnormal coronary angiography previously, then this time as well the patient would need invasive coronary angiography if the patient is coming with chest pain. So in a nutshell, so someone is coming with chest pain and you calculate the heart score, that's intermediate risk pretest probability, and the patient has no known coronary artery disease. Then you look at the prior testing. If the prior testing was recently negative and was within the warranty period, you can discharge the patient. If it was inconclusive or mildly abnormal, you can consider getting a CCTA. And depending on what the CCTA shows, you may need FFR CT later on if it's inconclusive. And then if the prior test was moderate to severely abnormal, then you can directly send the patient for ICA, that's invasive coronary angiography. Now, if there is no prior testing, then depending on the institutional expertise, you can choose between getting a stress test or a CCTA. Stress test can be exercise, ECG stress, or a SPECT stress test, or a PET, MPI, or a stress echocardiography, or stress CMR, that's cardiac MRI. Depending on the availability, and from that stress test you can find out whether it's negative. If it's negative, then you can discharge the patient. If it's moderate to severely abnormal, then this patient would eventually need invasive coronary angiography. If it's inconclusive, then you may consider getting a CCTA, and even if the CCTA is inconclusive, you may need FFR CT. And if again FFR CT in that case is less than or equal to 0.8, then this patient would eventually need invasive coronary angiography. And then lastly, if let's say someone is at intermediate risk and they have known previous CAD, and if the previous CAD was non-obstructive, you may want to consider getting a CCTA or stress test. And depending on what the CCTA shows, if the CCTA is negative or if there is no change, then you can discharge the patient. Or if the CCTA shows obstructive coronary artery disease, that is, so by definition again obstructive is more than or equal to 50% stenosis of the coronary artery, then the next step would be getting FFR CT. And then again, what do we mean by FFR CT is basically fractional flow reserve. Basically we are getting that from the CT. And how do we get FFR CT is we use the formula pressure in the distal coronary divided by the aortic pressure, or basically pressure proximal to the lesion. And if it's less than or equal to 0.8, that means if the aortic pressure is high than the distal coronary pressure, that means there is a hemodynamically significant stenosis which would benefit from revascularization. So if the FFR CT is less than or equal to 0.8 or moderate to severe ischemia, this patient would eventually need invasive coronary angiogram. So basically we were talking about acute chest pain, intermediate risk, and a known CAD. And then you if the previous known CAD was non-obstructive, you can consider getting a CCTA, and depending on what the CCTA shows, there would be next steps. You can also defer testing and intensify guideline-directed medical therapy depending on the clinical picture. The other scenario would be if the patient has a known CAD and a known obstructive coronary artery disease, and if they have high risk coronary artery disease, or if they have frequent angina, then you can directly send this patient for invasive coronary angiography. If they don't have high risk features or no frequent angina, and they are coming with acute chest pain with a known coronary artery disease, then you may want to consider getting a stress test like a stressed CMR, stress echocardiography, or stress PET, or stress SPECT. And then if that's normal, then you can discharge the patient. If that's abnormal, then you might have to consider for invasive coronary angiogram. One important thing to keep in mind with all this intermediate risk patients with known CAD, the goal is optimizing GDMT, because you already know this patient has coronary artery disease, and if they are coming with chest pain, that means it is likely that the coronary artery disease or obstructive coronary artery disease is causing that. So optimizing guideline directed medical therapy is always going to be the correct choice. And then lastly, in all the clinical decision pathways, if the patient has high risk for acute coronary syndrome, and if they have new ischemic changes in the EKG, or troponin confirmed acute myocardial injury, or new onset left ventricular dysfunction with ejection fraction of less than 40%, or moderate to severe ischemia on stress testing, hemodynamic instability, or even let's say heart score which is high, then this patients would benefit from invasive coronary angiography, and that is recommended. That pretty much concludes about the chest pain as per the ACC and AHA guidelines, and thank you for listening.